Breathing difficulty. So some signs: observing pale or cyanotic skin. So where is this patient going to be cyanotic? Most likely, Michaela.
No lips.
The lips. In severe cases, fingertips.
Fingertips.
Yep.
Sorry.
No, good job. Thank you. Now, when the patient is breathing, is having difficulty breathing, who can tell me why pedal edema would even matter? Like, why pedal edema? First of all, means swelling of the ankles. But why does that matter? If your patient is having difficulty breathing, what is that a telltale sign of? Anybody think they may know?
I think does it have to do with? I'm just taking a guess. Just water.
Go ahead. It's actually, they have cardiac heart failure. So when the patient has heart failure, blood is taken to your heart from the bottom of your body via the inferior vena cava. Remember that from the last chapter that we talked about? So the inferior vena cava carries blood to your heart from the bottom of your body. Now, if you have heart failure, all heart failure really means is that your heart sucks. It's not pumping as good as it should pump. So what does that mean for your patient? That means that they're gonna have blood backing up. So if your patient has heart failure and on the right side of the heart and blood is going backwards, gravity takes over, right? And the blood pulls down and it settles on the ankles of the patient. That is pedal edema, and it's from heart failure. Now, on the left side of the heart, the exact same thing is happening. If it's heart failure, it's heart failure all the way around. If they have heart failure on the left side of the heart, blood is being backed up into the lungs because blood is taken to the left side of the heart from the lungs, right? After it gets oxygen. And if blood is being backed up into the lungs, they're essentially kind of like drowning themselves because their blood is pulling in the lungs and that's interfering with that gas exchange. Okay? And so that's a hint that they're having difficulty breathing, they have pedal edema. It's a possibility that that's the reason why. It's because it could be linked to cardiac heart failure. Any questions about that? Nope. All right. Let me make sure I'm still okay. I'm still recording. All right. So oxygen saturation, reading less than 95% on the pulse oximeter. So again, if you don't know this now, you want your patient's O2 sat ideally to be between 90, 95, and 99. I would write that down if you don't have that down. If your patient's O2 sat is below 94, it's a good idea to put them on oxygen. Unless they have COPD and that they're normally like at an 89 or 88. In which case, most likely they'll tell you, or somebody will tell you.
You know, since you're on that topic, I know that someone that has COPD, if you give them too much oxygen, it'll kill them because they're not used to that much. Could you explain why?
Yeah, let me see if I can break that down. It's been a while since I had to explain that. So normally, we have these things called chemo receptors, right? So the chemo receptors, they're on your aorta and they're in your carotid arteries. And what they do, the chemoreceptors, they measure the amount of CO2 in your bloodstream, NO2, right? And so what happens is that whenever let me see, hold up. So CO2, whenever CO2 increases in the bloodstream, when the CO2 increases in the bloodstream, your chemoreceptors send a signal to your respiratory center, and that's in your brain. And it sends a signal to increase respirations. And that's on a normal person. So chemoreceptors will measure the CO2 level, and the CO2 levels get high, then the chemoreceptors will send a signal to your respiratory center so that you can increase breathing. Now, on patients that normally have high amounts of CO2, being your COPD patients, they normally have a high amount of CO2 and lower than average oxygen level. Now, so that will reverse. So instead of going off of your CO2 levels, now we're going off of your oxygen levels because it just shifts on them because they're used to having high amounts of CO2 and low amounts of O2. So on your COPD patients, whenever you give them too much oxygen, because they're used to having low amounts of oxygen percentage, their brain, their chemoreceptors will stop sending that signal to the brain to increase respirations because they're going off of their O2 levels now. So if the O2 levels are higher than normal, now the patient's body is thinking, well, then now I don't have to breathe as much because I have a high O2. Does that make sense, kind of?
Yeah, it makes sense.
I know it's a little complicated, but I try to make it simple. But that's fine. All right, so this patient, here you go. Tripod position, and it's pretty much just pointing out where you would find certain things, but it's pretty obvious, like wheezing, flaring of the nose, cyanosis, you'd find it on the lips, all that stuff. All right. So breathing difficulty, observing noisy breathing. Audible wheezing. So this is when you are walking up to the patient. During the primary assessment, if you hear wheezing without you even putting on a stethoscope, that's obviously an issue, and they're having either most likely asthma, or it could be like a severe allergic reaction. Bronchi would be fluid in the lower airway, and it sounds like actually, you know what? Actually,